I have great pleasure introducing Dr. Bill Harrell. Now, Bill is really a legend in this field. He did his orthodontic residency at University of Pennsylvania back in 1977. He's certified with the American Board of Orthodontics, but what makes him, I think, very unusual from the standard orthodontist, he's also certified in dental sleep medicine. He teaches at the University of Alabama in the orthodontic department. And one thing I found analogous, I learned all my airway really as a young uh, orthodontic resident from one of the greats in the field. And you know, everyone's heard of Dr. Ricketts. And I remember visiting Dr. Ricketts' office, and he was very proud that he was the first orthodontist in the United States to have a lateral cephalometric radiograph. You know, up till then, it was all sort of angle classification and looking at study models, right? In a similar way, Dr. Harrell was the first orthodontist in Alabama to have a CBCT, which you know, really revolutionized the way we look at airway. And he was also the first orthodontist to combine CBCT data with his 3D facial imaging, and that would have been over 20 years ago, which in itself is quite legendary. Bill Harrell, other than the main author in a new textbook on this topic, which I'll come to in a minute, he has been tasked to serving on the the American Dental Association's CAST screening program. And CAST, for those who haven't heard of it, stands for Children Airway Screening Task Force. And it's an ability of looking at or helping nurses who go out to the schools to be able to come up with a classification system to help identify children who may have signs or symptoms of sleep disordered breathing. And it'd be great if the Australian Dental Association were to integrate something as forward as that. So I'm really going to pick your brains about that today, Bill. Because I believe you're looking at children like from 2 to 12 in that sort of demographic.
That,
yeah.
Right.
And I know my very good friend and colleague, Dr. David McIntosh, who's helped me with a lot of my research over the years, and obviously we shared many patients together, is very excited about your new collaboration in the textbook. Now, he's given me the name, Growing into Breathing Problems, the Quest for Collaboration or for Collaborative Lifetime Solutions, but I believe you may be changing that title.
We did, and that's going to be that's going to be a chapter title, the Growing into Breathing Problems. We felt like that we needed a title. The whole goal on this book was to try to attract the medical side. I have it heavily medically weighted. In other words, a lot of the 30 co-authors we have trying to chase cats around, but uh, a lot of them are medical doctors, and I wanted it geared toward the medical, uh, just for that reason, because I felt like dentistry would kind of follow. So we changed the title to Sleep, Craniofacial Form, and Airway Function Disorders. And then it's kind of a subtitles, the interdisciplinary management or interdisciplinary assessment, diagnosis, management, and prevention.
I did my sleep medicine training in Australia, and one of my tutors was a guy who developed CPAP, Colin Sullivan. And even Colin Sullivan said, I developed this machine for the end state problem, but really what we should be doing is trying to prevent people from getting to that. So all the big names in sleep medicine have all talked the talk about prevention, and yet most of the treatment modalities we see are still, you know, the two-jaw advancement surgeries, the CPAP for life, dentists are getting into mandibular splints. But they're really, I think people have lost the ability to phenotype maybe the craniofacial pattern early and see what can we do for these kids.
The last word in the title, in the subtitle, is prevention.
Right. Right.
You know, and I think it's really where we orthodontists may be missing the boat. I mean, here's what I liken it to. This is I'm trying to get some figures on this. Is one of the things that's holding my chapter up because I'm trying to get some of these figures. But if you think about club feet, an infant that's born with club feet, when do they treat that? They treated it next day, within a
Yeah.
week,
Yeah.
within a month at least. I mean, they don't wait and go, well, let's just see how the child's going to walk
Yeah.
and then
Yeah.
decide what we're going to do. The
Yeah. Yeah.
Ponseti method, Ponseti is the one that developed the casting of the feet or putting braces on them. And they take the club feet and they overcorrect them.
Yeah.
And then
Yeah.
they bring them back to the middle.
Yeah.
And then now you're not exactly right. Your feet may not quite, but they're better. But then they take corrective shoes and detail it. So the whole point is you got orthopedic stuff up front, and then you're detailing the feet, or what are we detailing the teeth with? Braces. It's kind of crazy because it makes the whole brace phase so much easier. I mean, if
Absolutely.
you go in there
Yeah.
and get 4 and 5 year olds, you ought to look. I had a case the other day that just came in from up in Huntsville, Alabama, which is 4 hours away from me. And we're treating the daughter, but the little son, he's got his 6 year molars in, but the only anterior teeth he's erupted are the lower centrals. So none of the other, all up, everything's primary teeth. And but the mother's real airway focused, so she wanted me to see this child, and I'm all you got to do is tell them to smile,
Yeah.
and what you do is you see that, and you look at these primary teeth, and they're like this, they're all touching,
Yeah.
and they're and a little bit of a deep bite, and there's no room. The idea is there needs to be a nickel.
Yeah.
You should be able to
Yeah.
put a nickel between all the teeth,
Yeah.
primary
Absolutely.
dentition. But we've we've kind of geared ourselves toward thinking, okay, straight permanent teeth are all lined up and they're nice little pearls, like everything's lined up. Now, where you put it three-dimensionally in space makes a difference because you can make a pretty smile, but you can have retrognathic maxilla and mandible. The teeth look beautiful, but the whole face is collapsed. And that's what's been evolutionarily, that's what's happened to
Yeah.
us
Yeah.
as a
Yeah.
human population. The
I know I had some chats with Dr. DeLuke, and you know,
Yep.
he makes a valid point that no orthodontic resident is taught how to even look at a 4-year-old, let alone how to treat a
Yeah.
4-year-old. And if you've got a busy uh, production line practice where you have like a 5-minute rewire and you've got 10 chairs going, having that
Yeah.
maybe slightly uncooperative 4-year-old is really going to not make your day. And I
Yeah.
said, knowing what I now know, I would have probably changed my practice name to No Gap Orthodontics, right? And people will say,
Yeah.
well, what's that mean? And in Australia, there's a group of dental corporates, and they're called No Gap Dental, and people like them because they accept insurance only, so there's no gap between the insurance and the fee, right? So it's not exactly what we call high end, right? But
Yeah.
if I said
Yeah.
no gap orthodontics, people would say, wow, that's great. I mean, he's only accepting insurance. But really what it
Yeah.
is, I'm saying if your kid has no gaps by the time they're, adult first molars erupting, that is a problem.
Yeah.
And now, I mean, when I graduated, we had to put bands on the teeth, and that would be hard enough.
Yeah.
Now
Oh
with
yeah.
metal printing, with 3D metal printing, it's so easy to expand a four,
Yeah.
5-year-old. And I
Yeah.
think more in our profession should do it because I've
Yeah.
seen, A, it's really easy to do, and B, my God, it improves facial development and airway. So I just think our profession needs to relook at that, where we're not worried about the teeth. And sure, yes, we can talk to the mum about extra space because the adult teeth are bigger than the baby teeth. But really, our focus is on the airway. And
Right.
I've come across many pediatric dentists who are killing this space. And most of my profession are sort of in a race to the bottom, dealing with aligners and seeing which brand they will use, at age 12, 13, 14. And yet the pediatric dentists are really leading the field because they're getting in at the
Yep.
appropriate age for the airway.
Yep.
Can that brings us on to maybe if you could explain a little bit about what you're doing as far as setting up that program where you go into schools and maybe you work with the nurses to be able to get a facial analysis to potentially screen for these sleep issues in children, because that to me is like should be around the world.
They all talk about sleep apnea in children.
Yeah.
That's the end stage of the problem. That's after you have waited for the club foot child to try to start walking and they can't.
Yeah.
I mean, it's so the whole point is to try to recognize these things early. And we know that if they can't breathe and they can't sleep and they can't oxygenate themselves, there's all sorts of cascading things that occur, cardiovascular, brain development. I can show some of that a little bit, but basically what we did, I kind of came up with this form, but we came up, we wanted just a 5 questionnaire. You got the pediatric sleep questionnaire, you got all these questionnaires that have 20 and 30
Yeah.
thing. And so we tried to boil it down into just basically these 5 questions. Does
Right.
your child mouth breathe? Do they have lips apart while awake or asleep? And then do they snore? Do they make noise? Do they pause during breathing? Do they extend their neck upward when they sleep? Because that's just, they're trying to open up the airway. Upon awakening, do they have dry mouth? Do they have headaches? Difficulty getting up in the morning after they slept 8 or 10 hours or whatever. Then we don't talk about ADHD, but the last one talks about, you know, behavioral and emotional
Yeah.
issues. We don't want
Yeah.
to tag them with the other, but basically, what this what this screening form does, any yes answer elicits, hey, there's a red flag. Of course, the more yes answers, the worse it is. I
Yeah.
mean, I've got people coming in checking off all of them, and it kind
Right.
of explains on the other end. This thing's been is now online, and I can talk to you about that a little bit. But it is from 2 to 12 years of age, and so any yes answer elicits, recommendation. We have another level B. So if you check yes in the virtual one we have, if you click yes on one of these answers, then it goes into another set of questions
Right.
to qualify it a little bit more. This is the paper form here. Now the parents fill out this. It takes a minute. Okay, check, check, check. We use this every time for kids. It gives me a start of, oh, I see your child mouth breathes, or I can see it over there, but then they just check it off. And even if they check no, that that doesn't necessarily mean no,
Right.
because they may
Right.
not know. Does your child snore? Well, I don't know. I don't sleep with them. So maybe they put no or something. But then I qualify and I look at them. They got allergic shiners and all this kind of stuff. And then I get deeper into it. So you can't just take it with a grain of salt. You got to have enough information to be able to start questioning, even if they have checked all no. Do
We
that.
uh we certainly identified now here's the thing, and I always say this in all my lectures, that the Christian Gumno developed AHI for adults, but there's no
Yeah.
research to support it for children. They just sort of made everything a third of
Right.
the adult size, right?
Yep.
And I know
Yep.
kids, particularly these kids, they're not still enough long enough to record an apnea. So I get so many
Right.
parents who get a sleep study and they come back saying, well, the doctor says nothing wrong with my kid because he
Yep.
doesn't have apnea. But I know there's a
Yep.
lot wrong with the kid.
And here's something that Karen and I coined the term, the wine bottle theory. You're into wine.
Yeah.
So you can take a bottle and you can make the base just as big as you want to make it. Put a lot of wine in it. You got a big old fat base, but you
Yeah.
still got a little narrow top to pour it out of.
Yeah.
You can
Yeah.
only pour it out so fast over here. It's this, not this.
Yeah.
Like you can
Yeah.
make the pharyngeal area just as big as you want to, but
Yeah.
if they can't breathe through the nose, they're
Yeah.
congested, they have a deviated septum, they got small
Yeah.
nares, they got enlarged turbinates, enlarged adenoids in the back. I
Yeah.
don't care how big you make the pharyngeal airway. So in an adult, 5 and above is considered sleep apnea. Five events per hour is considered having sleep apnea, and then you got mild, moderate, severe. Well, what if you're 4.9 or 4.8 and you're sleepy and you look tired and whatnot? They're gonna say you don't have sleep apnea. Problem with home sleep test, it does it. And if you get a home sleep test, if it says you have sleep apnea, then more than likely you do. But if it says you don't have sleep apnea, that doesn't mean you don't have
Right.
it.
Right. I
So
mean,
you can't.
I like this analogy because, many orthodontists are now looking more closely at CBCT, but CBCT is not great for looking at nasal valve collapse, for instance,
Right,
right?
exactly.
And I think if you add that, I remember growing up, one of my favorite shows was Get Smart, with
Yep,
Agent,
yep. I remember that with
what
the
was his
shoe.
name? I remember I was in love with
Yeah,
Agent 99. I think that was the girl,
99. Yep,
and
yep,
I can't
yep.
remember the name of the actor, but it always started where he'd have all these gates he'd have to get through to get to, the end. And so when you think
Right.
about it, we're dealing with the gates right down the end, but the front gate to let him in is still closed. And that's
Still
so
closed.
what you're describing here. And I
Yep,
think parents get
exactly.
I mean, we in
Yep,
Australia, we are in a land that has very unusual fauna and flora, and all of us don't belong here. So 90% of people in Australia have nasal allergies, right?
yeah,
Um,
yeah,
and the
yeah,
lucky 10% that don't, we're a sporting nation, so they're probably going to break their nose at some stage, but no one's measuring that, right? And
yep,
you might give someone the world's best oropharynx opening, but what's the
yep.
point if the nose? So I think this is
If the
fantastic.
nose, it's like Karen says, she goes, look, you don't ask a patient, how's your blood pressure?
Yes. Yeah.
You measure the blood pressure and tell
Right.
them what it is.
Yeah. Yeah.
Why aren't we measuring nasal flow and nasal resistance? It's an
Yeah.
objective measurement, but
And not only that, but you know how many parents say, well, my kid got their adenoids and tonsils out, but I really don't notice any change in the way they breathe
didn't
and
know
blah,
any
blah, blah.
changes. And
This
because
is a
it's still,
quantitative
it's
way of
still a,
measuring,
yeah.
yeah. And I've
And it
done,
doesn't take long. You could do this, and I don't know. We've got it down to probably less than 3 or 4 minutes.
right,
Not
right.
even that much. It take a minute. I mean, you you kind of put a stopper in their nose, make sure it's stopped up on one side. You put the mask on. You have them breathe 4 times naturally, and that's it.
Yeah,
It's
yeah.
that quick. And
I mean, the reception backslash nursing staff can do it in the waiting room before the consultation. I
exactly.
mean, yeah, yeah. That's
You
amazing.
could
That's
even
amazing.
you could be this could be even part of that cast. I mean, if you wanted to get into doing it in schools, I mean, you could
Yeah,
literally take this and it's like taking blood pressure. I mean, the
yeah, yeah.
nurses could go in and do that, but it's not that hard to do.
Right, right.
Yeah,
And I mean, to me, I can understand right now that you can use this to maybe help diagnose sleep disorder breathing problems, but I think more important, you can help quantify the changes during and after whatever treatment you do. So everyone says, "Well,
exactly.
I use this appliance, and I use that technique." Well, look, put your as we used to say, put your plaster on the table. Here,
Yeah,
you put your data and say,
put your
"Well,
data
sure."
there.
Yeah,
Exactly.
this is amazing. You
Yeah.
mentioned Ghazal, and the first time I listened to Ghazal speak, and he was talking about his brain mapping and how kids with
Yeah.
undiagnosed sort of breathing, they're losing IQ points every year, and when you
Yep.
know that the brain grows so quickly between 0 and 2, and if there's oxygen depletion to that from whatever source, I mean, how valuable would be that for any screening protocol? And I think the general public are a lot more aware of the importance of nasal breathing thanks to
Yeah.
the
Yeah.
books that are available, social media, obviously.
Oh yeah.
And I was gonna, ask at some stage about this whole TikTok trend of taping your mouth, right? Because
Yeah.
I get so many patients asking me about that. Um,
Yeah.
but the author that wrote the book is Breath, right?
Breath.
Yeah, yeah. I mean, he's got a huge following, and I get patients
Yep.
now who, when I started talking about, the adverse effects of mouth breathing, people would look at me like, "What the hell? I'm here to straighten my kids' teeth." Now they're very
Right.
interested because they've picked it up on social media chat. So I think now's the
Yeah.
time to really encourage the understanding of, yep, we all know that nasal breathing is important, but what can we do to help that?
Yeah, exactly. And here was a study that really brings it to light. Uh, they did this group, the investigation on the effect of oral breathing on cognitive activity using functional brain imaging. So they
Yeah,
used MRI to look at patients that nose breathe versus mouth breathing. Really simple. Mouth breathing, orthodontists, I mean, that's mouth breathing. Even Angle talked about it. Is even talked about in the 1800s that mouth breathing creates a whole craniofacial change in the way the jaws develop. I mean, it
yeah,
just
yeah,
does. And then, of course, the monkey studies and all that stuff showed. But what they did is they looked at the results showed that more brain activation and connections during nasal breathing than during oral breathing. In other words, about 15 areas of activation you can see, these lighted up areas of the brain were lit up during nasal breathing versus less during mouth breathing. This can be significant evidence to demonstrate that oral breathing is an inappropriate method for intellectual activity using brain imaging techniques. These findings also suggest that any solution for oral breathing should be considered not only for dental care, because we know mouth breathers, there's more chance of caries and drying out the mouth and all that,
yeah,
but also for working memory. And I think if parents, if they understood this, it's like, whoa, my child's mouth breathing, it can affect brain development.
yeah,
I
yeah.
mean, we don't realize. I think here's another here's another one. Nasal breathing actually synchronizes brainwave oscillations in the piriform cortex, amygdala, and hippocampus. So here's a patient nose breathing. I didn't really realize this, but look what happens. The brain is kind of pumping differently
Yeah.
than I don't have a mouth breathing one, but anyway, it's just it's just interesting, that orthodontics should be more than just sitting here straightening teeth
Oh,
and making them
absolutely.
pretty.
And on that point, I mean, I've read a lot of stuff on that sphenobasal pump and how,
Yeah, yeah.
some kids suck their thumb to stimulate exactly what you're
To
showing.
stimulate that.
Yeah,
Yeah,
because their palate's so narrow, their tongue
yeah,
can't do that. And
yeah.
they mouth. So
Good point.
that right there is just absolutely amazing. And on that point, I think when we're talking about, that triad between bruxism, and sleep disordered breathing and TMD. I don't think you can
Right.
separate those. I think in dental
No.
school we've tried to sort of say, well, that's that problem, that's that problem. But really, the more patients I see that come
Yeah.
in, particularly with intracapsular problems, you start asking sleep history, and you start asking, and many dentists, they say, well, look, how can someone be a mouth breather and a bruxer? And I say, well, what you don't realize, bruxism is for a short period of time. So, you we now realize, thanks to that excellent research from people such as Dr. Levine in Montreal, sleep bruxism, that bruxism, which we as dentists view as a bad thing because we see wear on teeth, is actually the body's protective mechanism for airway. Rather than do a course on putting Botox in the masseter to prevent the body's way of coping, right? Why don't you learn about what's causing the bruxism?
Right.
And many times it's airway related. So I think the way to get a lot of dentists and orthodontists here is we all have patients who brux. Well, why don't we look deeper and say, well, how is that related to the airway? So it's just fascinating stuff. And I think
it really is.
I remember Bill Hang always used to use this quote. He said, if I straighten teeth for someone and I miss their airway and I can't improve their quality of sleep and their concentration, their performance at school, what have I really done? And he says, it's like straightening the deck chairs on the Titanic. And I love that saying because, why bother? Why bother? Right. Well, well, it's been really great to chat to you, and I am so eager to get this measurement into Australia, and I will definitely speak to all, like, ears and throats are probably my biggest referrers. And if I can say to them, listen, we're all looking at the same thing here. Nasal valve collapse is something we'd like to measure. We'd like to see, how can we improve it? And Audrey's a great researcher. So if she's got this at University of Pacific, I can see a study coming up now already where we can measure before and after based on different treatment modalities. And again, those people who still boo-ha expansion for whatever reason, it'd be really interesting to see what impact this would on the airway. If we can just conclude by, if you can tell me a little bit about your upcoming textbook. I know you're very much focusing on the medical model, but really, I'm looking at some of the authors. It's just, we're all just waiting for this book to come out, and I think I know how hard it is to do something this in depth. But the other thing would be, we really need a quintessential book for parents, right? Like to sort of say, hey, my kids not doing well at school. My kids got behavioral disorders. What can I do? Because unfortunately, let me share some with you. In Australia, we have the highest incidence of ADHD than any other population per capita. We have the highest uses of Ritalin than any other population per capita. We have the highest rate of teenage suicide, and we're the lucky country, right? So the question is, what are we missing here? And I can tell you, all of these problems go back to sleep, right? And I think there will be a day where there will be a specialty within dentistry which would be dealing with dental sleep medicine. There has to be.
It has to be.
But until that time comes, I think every dentist, in fact, every person involved in oral health, whether it's a hygienist, oral health therapist, periodontist, endodontist, they're all gatekeepers of the airway. And I think we pick up these problems in kids well before they manifest themselves into the end state, OSA, etc. So I think what you're putting through here is a powerful thing for parents. And I know how successful Shireen Lim's book has been, educating parents in that regard. So it'd be great to see a resource for parents, and mums. There's something about mums, they just get, when it comes to their kid, they kind of
That's
think
where you got
outside
to
the box.
concentrate.
That's where you got to concentrate. You've got to concentrate.
David and I are forming this thing called the Airway Breathing Academy.
Right.
And part of that is going to be number one for professional education, but for also parental education.
Yep.
Now,
Yep.
David's got like 4 books or something that are geared toward parents.
Yep.
Karen Davidson has got some kiddo books too
Yep.
that are really good. The Nose Knows and some other
Yep. Yep.
how to anyway. And Shireen Lim, those you know, a lot of those parent oriented books are out there. So I would have anybody that any parent that may be on here or whatever.
And just thinking out aloud, one of my good friends from dental school days, his name's Dr. Chris Farrell, and he developed the MyoBrace appliance, and it's hugely popular
Yeah,
around the world. But what's his
yeah,
biggest failure? The kid not being able to wear it at night because they can't
yeah.
breathe through the nose.
Because they
So
can't breathe. Yeah,
for him
yep,
to be able to have this as a prerequisite before he prescribes the MyoBrace, his
yeah.
success
That
rates
would
will be
be.
even better because you
Yeah,
fix the nose and then the kid can use this because
can use it.
there's exactly absolutely. I'm
Absolutely.
excited. I think
Good.
this is the missing link.
Perfect.
So thanks very much
Perfect.
for
Yeah.
all you've done
Yeah.
for the
Thank
profession.
you.
Thanks very much for getting up at 5 a.m. for this
That's
interview.
okay. We're good.
and and it's been so nice to talk to you. And I look forward to catching up next time I'm in the US.
Good
Thanks
deal.
again,
Thank you.
and keep up the great work. We'll catch up soon.
Okay. Thank you,
Bye.
Derek.
Bye.
Appreciate it. Thanks. Bye bye.